and welcome back to the EUO podcast. My name is Renu Eapen, urologist at the Peter MacCallum Cancer Centre here in Melbourne, Australia. I'm also the digital media editor for the European Urology Oncology journal, as well as co-host of GUcast. And I'm bringing you the EUO podcast recorded right here in the GUcast studio. So it's the middle of a freezing winter in Melbourne, but of course it is summer in Europe and a great time for the June edition of the EUO journal to drop. Today we'll bring you two priority papers from the June edition, as well as a special guest on the EUO Bio segment. But first, big news this week that the latest 2024 journal impact factors have been released, and excellent results across the family of European urology journals. European Urology Oncology have jumped a whole point from 8.3 to 9.3 under the leadership of Editor-in-Chief Morgan Rupre. The Platinum Journal, European Urology, stays strong at 25.2 and, of course, continues to lead the ranking for urology journals. And all the other EU journals all rising, 4.9 to 5.6 for EU Focus, and a big jump, 3.2 to 4.5 for EU Open Science. So huge congratulations to the entire team, particularly Editors-in-Chief Alberto Briganti, Morgan Rupre, Christian Gratzky and Jochen Walsh for their leadership. These journals continue to be a great place to publish your research, and this is just another reminder of that. So back to the June edition of European Urology Oncology, very prostate cancer heavy, but we couldn't go past a PSMA PET-CT paper and correlation with oncological outcomes, as well as a great multi-institutional review of SBRT for the treatment of primary renal cancers. So lots of great content coming your way. Stay tuned. All right, so this edition of the EUO journal is quite heavy on prostate cancer, as it often is, and we really couldn't go past a wonderful paper on PSMA PET-CT in staging. So this paper is entitled Early Oncological Outcomes in Patients Who Underwent Staging PSMA PET-CT compared with conventional imaging before radical prostatectomy and extended pelvic lymph node dissection. And it gives me great pleasure to invite three of the authors into the studio today, or at least over Zoom. I would first like to invite Dr. Rosemarjin Ettema from Amsterdam. She's the first author of this paper. Rosemarjin, congratulations and welcome to the EUO podcast.
Yeah, thank you so much for the invitation. We're so excited to be able to talk here about our research.
I love having fantastic women on the podcast. Tell us a little bit about yourself.
Yeah, I'm a PhD candidate at the Amsterdam University Medical Centers. I've worked in clinic for some years, and now I started my PhD. It's been 2 years already, so it's going fast. And this is actually my first author piece, so wow. I'm really excited to be able to be here.
You will always remember this one, Rosemarjin, and in the EUO journal. So that is a big deal. Congratulations. Such a beautifully written paper. We'll get back to the important information in the paper, but I do want to introduce your two senior authors of the paper, Professor Andre Vis from the Amsterdam University Medical Center in the Netherlands. Welcome, Andre, to the EUO podcast.
Thank you. Hello.
Hello, welcome. And of course, Dr. Roderick Bergh from Erasmus Medical Center in Amsterdam. Welcome, Rod.
That's right. Thank you for having us.
And Rod, you are no stranger to GUcast, of course. We recently featured you in the EAU highlights. You were the discussant for the NeuroSafe Proof game-changing plenary session at EAU. And you're also no stranger to Melbourne. You did your fellowship here at Peter Mac. Do you miss it?
Yeah, I just realized it's more than 10 years ago already. Wow. So I'm getting old, but I will never forget my fellowship here in Melbourne and my time with Declan.
That would have been your humble beginnings in PSMA PET-CT, right?
Exactly. You taught me how to do it, and then we started doing PSMA in the Netherlands as well. Now we have a lot of PSMAs for many years, so
now you guys are flying with it. So that's fantastic. So I might go back to Rosemarjin for a minute. Rosemarjin, do you want to go through the paper and the study itself and the main findings from it?
Yeah, definitely. So what we did is we tried to analyze whether the PSMA PET-CT has changed the landscape of the people we treat with surgery. And that's because PSMA is widely available in Holland, which is very, very nice. And I think from 2016, 2017 onwards, all our patients pretty much received PSMA staging. We also know that the PSMA staging changes the treatments that patients are selected for. And that's why we came up with this research. So does that change in treatment change the oncological outcomes of patients who are opting for surgery in this era? Unfortunately, there was no control group, so we had to include a historical cohort. We started including in 2013 up until 2016, and then from 2016 onwards, that's our PSMA cohort. We included up to 1,300 patients, or a little over that, pretty much half in the historical cohort and half in the PSMA cohort. We then did a propensity score matching to ensure that the baseline characteristics, especially pre-operatively, were similar between the two cohorts. And that left us with 440 patients in both cohorts for the next analysis. And we then looked at the oncological outcomes of those patients. At first, the biochemical persistence after 6 weeks after surgery, we saw that there was less biochemical persistence in the PSMA cohort versus the historical cohort. We saw that it was 13% versus 19% in the historical cohort, which is quite a big difference. And then afterwards, we looked at the biochemical recurrence. If you just look at that plainly, then of course the biochemical recurrence will be higher in the historical cohort because they had longer follow-up. And that's why we performed a time-dependent Cox regression analysis. And that Cox regression shows both univariable and multivariable that there is a big difference between the two groups. So we show that the PSMA cohort has less biochemical recurrence or a higher biochemical recurrence-free survival. And that is independent of other risk factors within our cohort. So in conclusion, we believe that the landscape has changed. We perform our surgery on has changed, and that because of that, our oncological outcomes are different now than before the
Yeah, so interesting. And it is difficult to have a control group, isn't it? Because the standard of care has certainly changed. And, you know, and we've known this for quite a while now, and it's in all the guidelines, especially the European guidelines, that if you're living in a place where PSMA PET-CT is available, there's no real role for CT and bone scan in staging these patients. So it's very difficult to have a control group in this instance.
Definitely. And it would be unethical to make a randomized controlled trial, really. So
yeah,
we cannot really do it. It's not feasible. Nobody's going to do that for us. So
Andre,
we'll have to do it this way.
Yeah. Andre, I might go to you quickly. So, you know, since the PRO-PSMA study, we've seen that PSMA PET-CT is superior to conventional imaging in terms of staging, much more accurate, less equivocal studies, lots of advantages, and it had a bigger impact on management decisions. But what we didn't know at that time is what is the long-term oncological impact of these newer novel imaging. And these things can take a long time to see. So this study is quite important when you're looking at that oncological impact of these novel imaging over conventional imaging.
Yeah, correct. That's indeed true. So what we need to consider is that we look at a selection of patients in this manuscript, because these patients underwent PSMA PET imaging compared to conventional imaging. And when we look at these papers and look at the data, we see that the patients who underwent PSMA PET imaging did better. So they had a better biochemical progression-free survival, as well as a lower BCP rate. But we need to know that this is PSMA imaging. So in fact, the prognosis of the whole group together, so those who underwent PSMA imaging as well as who didn't, might be similar. So we don't know exactly what is the oncological outcome in the long run. But we feel that this is selecting patients better to undergo radical prostatectomy.
Rod, when I look at one of the tables of the preoperative characteristics, I mean, this is not the propensity score matched one, but according to the risk classification, the number of patients who were in the high-risk group was 72% in the PSMA cohort compared to 51% in the historical cohort. Why do you think that is? Do you think that sometimes conventional imaging can can overcall metastatic disease and some of these patients may miss out on surgery?
So I think there are different scenarios which can explain that. One of the reasons is I think that the whole diagnostic algorithm has been changing over the past few years. The indication to do any cross-sectional imaging has, I think, decreased to also include intermediate risk disease. And I think that MRI has been used more and more during that study period. So targeted biopsies have become much more normal, also providing a stage shift with higher Gleason scores for actually the same risk tumor. So I think there are multiple reasons that can explain that. And I think that despite that higher risk, then having a lower biochemical recurrence rate, that makes it, I think, extra special to see that the PSMA group, performs better than the conventional imaging group. And I was also a bit surprised, actually, that the number of nodes and the number of PN1 patients and the number of positive nodes was actually comparable between the two groups, while my gut feeling would have been that the conventional imaging group would show higher risk of positive lymph nodes, but that's not what the analysis showed.
Yeah, so that's a really good point. The rate of node positivity was actually fairly equal between the two groups. Did you look at how many of these patients had positive nodes on imaging? So for instance, PSMA PET CT, and went on to have surgery and extended lymph node dissection anyway?
Well, I guess in selecting patients for radical prostatectomy, I guess we didn't select patients with node-positive disease on modern imaging, I guess. So when we look at the data between the historical cohort and the PSMA cohort, there are some differences. Differences in tumor stage, difference in tumor grade, which might explain some of the differences. So that's, I think, important to notice in this case.
And Renu, I think it's important to realize that the group that did not undergo prostatectomy due to the fact that they had a PSMA and probably distant metastatic disease or a high burden of lymph node disease, we don't know what the outcomes were. And we are not exactly sure that their treatment was better after being, deselected, excluded from prostatectomy. They may have become undertreated maybe due to that PSMA. So it's all about selection. And I think we should be careful not to, also to focus on the group that was excluded from prostatectomy due to the PSMA. It works two ways, I think.
Yeah, I think that's
correct.
really important, especially when PSMA PET CT was starting and you captured a little bit of that time point as well, when you really don't know what to make of these nodes that light up on PSMA PET CT when
like
they're
a
negative
small
on
red
conventional
lesion that
imaging.
was excluded from prostatectomy.
Yeah, that's very important. Andre, you're about to say something, sorry.
Yeah, I think it's important to notice that we select now patients who have a higher chance of cure. So we notice now that the BCR rates and the BCP rates are lower in this group. So we select patients and we can tell them now that they have a higher chance of cure of their prostate cancer by doing and performing PSMA PET imaging.
Yeah. So Rosemarjin, what do you think? I mean, is this really just stamping what we've always known since pro-PSMA, that it's the better imaging modality, that those who are still perhaps considering staging with conventional imaging now have another reason not to do that? There's oncological benefit.
Yeah, so it depends on the availability, of course. So that's the first thing. If it's not available, then you cannot do it. But I do believe that in this cohort of patients, that we make a more patient-tailored approach. Like the oligometastatic disease that we do find with the PSMA that we wouldn't have found with conventional imaging. I think that's the important or the interesting field that we still need to find out what to do with those patients and how, which is outside of the scope of this research, but it might be next.
Very good. Rod, I want to talk briefly about your PSMA Select trial. So, I mean, you know, one thing with PSMA PET CT is, can it replace the utility of a lymph node dissection? So tell us about the PSMA Select trial. I think it's going to be a very important trial going forward. You're almost nearing the end of it, aren't you?
So it's a Dutch trial. All the Dutch prostatectomy centers actually participate. So there's a very nice national effort. We randomized patients with a negative PSMA to undergo lymph node dissection, yes or no, and we follow them for 2 years, and biochemical recurrence is the primary endpoint. So we randomized close to 750 patients now. We need 40 more, so we estimate 2 more months of patient accrual. And I think that we will find, well, small differences in biochemical recurrence disease, which does not exclude the, well, scenario that there remains to be a high-risk group with a negative PSMA, with, for example, high PSA and high Gleason scores, that does benefit of receiving a direct lymph node dissection, if you consider the fact that removing positive lymph nodes is a good thing, because the whole idea of removing positive nodes, well, you can debate that as well. But if you think that removing 1 or 2 nodes in a PN1 patient is a good thing to do during the primary setting, I think there will always be a small group who does benefit lymph node dissection. But it's all about balance. It's all about the number of unnecessary lymph node dissections you do to find one of these cases. And I think that we already can agree, even without the PSMA select study results out there yet, that for a low risk or intermediate risk case, you need to do many, many unnecessary lymph node dissections, which does not make a lot of sense. But we're about to, well, show that in a prospective randomized matter soon.
Very exciting. That's something definitely to look forward to. So now this paper, Andre, is, it's focusing on biochemical recurrence and biochemical persistence. But of course, there is there's cancer-specific mortality, overall survival. And these are things that take years and years to find out. So what's next for you guys?
Well, sure, we have to follow these patients further to see if there's any change in longer-term endpoints, oncological endpoints, like castration resistance or overall survival. But as you say, it takes a long time. So we really have to see if PSMA imaging is improving these oncological endpoints as well. And so this takes time.
And you guys in the Netherlands, your PSMA PET-CT availability is much like Melbourne, isn't it? I mean, it's essentially universally used. Would that be right?
Yes, correct. So every patient who has intermediate disease, risk disease, or high-grade disease undergoes PSMA imaging. Yes.
Fantastic. Well, what a great paper. It really is. I mean, these papers are few and far between that really look at the oncological outcomes when PSMA PET-CT is used in the staging setting. So really interesting read. So thank you to all of you for joining us. Dr. Rosemarjin Ettema, the first author of this wonderful paper. Congratulations again, your first author paper, one to remember. And also to Rod van den Bergh and Andre Vis from Amsterdam for joining us. Thank you very much. All right, so we come to the second paper for this podcast, and this is a great paper on kidney cancer. So this is results of stereotactic body radiation therapy, or SBRT, for primary renal cell carcinoma in a large multi-center series. And I've got the co-first author with me. He's joined me on Zoom. This is Dr. Muhammad Ali, a radiation oncologist from Peter Mac, who has a particular interest and specializes in kidney SABR. Welcome, Muhammad. Thanks for joining us on the EUO podcast.
Good evening, Renu, and thanks for having me, and looking forward to discuss our work, which was published in European Urology recently.
Yeah, this is a fantastic paper. It's a retrospective series, but it's a multi-institutional series, which is great because it does make the findings more generalizable. So congratulations, beautifully written. I might get you actually to introduce some of the co-authors on this paper, because you do have a co-first author and they're based in France.
Yeah, so like you mentioned, Renu, it's a multi-institutional series. So the idea, it was basically raised by David Pasquier, who was the main, the figure behind this collaboration. And the reason was, as you know, we have worked a lot through IROC platform. So IROC is another international multi-institutional collaboration, but most of the centers were from Australia, Japan, or Canadian, and a few centers from USA. And we have only 1 or 2 centers from Germany. So he came up with the idea about pooling data with us and collaborating more with the European centers. So in the end, like David was the main one, and one of his resident, Ludwig, who was not able to join us today. She was the main person who coordinated with the data analysis and put on main effort on writing all these things.
That's right. So that's Ludwig Abencourt. We might not be pronouncing this beautiful French name properly, so apologies, Ludwig. But big congratulations to you and also to the senior author David Pasquia on this fantastic paper. And also, we definitely have to give a shout out to your colleague, Professor Shankar Shiva from Peter Mac, and you and Shankar really, and in particular Shankar, has really led a global effort on SBRT for renal cancer. Oh, he's just dropped off. Hold on one second, Mohammed. I can't hear him at all now. Say something?
I can hear you.
Oh,
can you hear me?
Okay.
Can you hear me?
Yeah, we got you now.
All right. Can you start at your
Yeah.
Do you get a little intro again or saying?
Oh yeah.
Oh
yeah.
So like you said, without Shankar's name, the Kidney Saver podcast are not complete. Like I think he's almost in authors or more than 90% of publications. And IROC was his idea, and even this collaboration, he was the main person behind that as well.
Absolutely. We're very proud of him. So huge congrats to the whole team.
Yeah,
So
thank you.
tell us about the paper, about your patient cohort and what your main findings were.
So this was a collaboration about from 16 centers. So one from Australia, we were the only centers, Peter Mac, which contributed around half of the patients, more than half of the patients. And then we have 15 centers, 8 from France, 6 from Italy, and 1 from Netherlands. So we end up with having 144 patients with, as expected, very older age cohorts, median age of 76, and slightly larger tumors which are not candidate for thermal ablation. So median size was around 4.4. Most of the patients had medical comorbids, including hypertension or diabetic. Baseline kidney function around 60, which is consistent with the published data. Like most of the patients coming for kidney saver, they have a baseline CKD of 3+, and that's what happened in this case as well. Almost 50% of patients baseline GFR of less than 60. And all these patients were defined as almost 80% defined as medically inoperable in all the MDM, but it could be different interpretation of medical operability. So different institution, it could be different, but it's most of the time it was decided in the MDM. So all the patients had stereotactic radiation to the primary. Dose was varying from 1 to 5 fractions, but the most common schedule was 26 gray in 1 or 42 in 3, which is our practice and which is supported by Fast Track 1 and Fast Track 2. And as already published, it has shown excellent local control. 5-year local control rate was 96%. 5 patients had isolated failure, local failure, or 4 patients had have combined failure with the metastatic disease. And the cancer-specific survival was excellent, 92% at 5 year, which is expected because of almost 90% of the patients T1. So we expect more than 90% cancer-specific survival for that cohort. And always important is kidney function whenever we are treating with surgery or thermal ablation. So the average decline in kidney function was -8, like from baseline 8 ml decline. And despite multiple patients with poor renal function, so we expect, and it's like all others, what we have seen across other publications varies from 5 to 15 ml. So that results were consistent, and we can generalize it on a multiple cohorts now. Like the average decline is roughly like equal to partial nephrectomy. And in this cohort, 2 patients underwent dialysis. Otherwise, there was no significant grade 3 or 4 toxicity. And 2 patients, basically 1% had grade 3 GI, which was nausea, vomiting, or diarrhea, and required admission for hydration. Otherwise,
Very
More
well
than 50
tolerated.
well tolerated, and more than
Yeah.
50% patients didn't have any side effects at all.
Yeah.
And one thing which is overall survival. So in this cohort, like overall survival was around 5 year, around 50%, which could be expected
With
in
the
a
medical
medical
comorbidities.
comorbid and median age of 76.
Yeah. Now
So
tell me, all these patients in your cohort, did they all have biopsy-proven clear cell cancer, or were you taking patients for treatment as they appeared on the CT scan based on those appearances, or did you have histological confirmation?
So in this cohort, 85% of the patients had biopsy confirmation, and with the clear cell carcinoma, the most common one, and few patients had papillary and chromophobe. 15% of the patients were treated without biopsy, but all those patients had a progression on serial imaging to be eligible for radiation. And this 85%, and that was the trend in IROC as well. So IROC, like 190 patients across 12 institutes, and it was 86%. And our own PIRMAC experience also consistent with 85, 86%. So in
Yeah.
real life, I would say like 8 to 9 out of 10, we end up with having a biopsy, but 1, 2 out of 10 end up with having SABR without biopsy. And I think this rate is acceptable because of multiple medical comorbids. Patient doesn't want to stop anticoagulation or doesn't want to go for invasive procedure in their 80s. And other thing could be most of the patients have a tricky location, which are not ideal for thermal ablation. So putting on needle can be a bit more tricky. But I think it's acceptable, 85, 90% of renal biopsy.
And also, we are entering into the era of molecular imaging for renal cancers. And now we've got, novel imaging techniques like CA9 PET, which can really give us an indication of what the underlying histological subtype is of a lot of these small renal masses. So histological confirmation may not be around for that much longer. What do you think?
Yeah, it could be like just particularly after the publication of that Zircon phase 3 trial, which have shown very high sensitivity and specificity with the CIX. And that was like large molecule, brentuximab monoclonal antibody, significant issues of like scan time after 4 to 7 days and low tumor to normal tissue ratio. But as you know, we are doing low molecule, small molecule peptides. So maybe in future we will not need biopsy. And another thing where the functional imaging can become more valuable for kidney saver, as you know, like you have seen after kidney saver, the most challenging point is response assessment. We see most of the time mass is sitting there the same size. They are not decreasing in size. And not like thermal ablation where we have a complete loss of contrast. We can still have a significant contrast enhancement. And you must remember our conversation just a week ago
That's
about one
right.
of our patient,
Yeah.
like 3 years post SABR, still contrast enhancement. So these kind of cases, I think maybe this functional imaging will help us to see whether there is any active tumor over there. So it's exciting time, but still it's too early to say whether we will have any positive finding. But
So-
for patients, definitely they can avoid maybe invasive biopsy.
Absolutely. And you bring up a good point, Mohammed, is that how do you follow up these patients post SBRT? So that's right. We had a mutual patient recently who had a very effective treatment for his renal cancer. The size of the lesion decreased, but it was still enhancing on imaging. So how do you know if there is ongoing response? Is it size purely? Is it size and pattern of enhancement? How do you assess ongoing response?
So at the moment, like particularly, even in this one, like 5-year local control of 96%. Unfortunately, we don't have a lot of local events to see the prediction of contrast enhancement and local failure, or the stability of mass and local failure. So currently we are just looking at the measurement. If size is not getting bigger, we are not concerned about. And at Vitamak, we never discharge our patient till they are happy to come in. Like we are following 8, 9 years since SABR. And even at 8, 9 years, you will see the patients with contrast enhancement. So we just ignore it if there is no progression. And Another thing, I think the important thing would be we we are following them up based on RECIST criteria, but there is a significant limitation of RECIST, like it doesn't take into consideration of treatment. If we look at the data from the lung saver, which is being used for last 15, 20 years, so they have looked at like 80 to 90% of the patients, they can have actually a progression based on RECIST, but never had the progression. So that is another thing. And we are looking at some of our data where we think rather than the maximum size, we should look at three-dimensional volume. There is a uh, more reduction in volume compared to size because most of the kidney masses are large, like a cylinder or a spherical. So it doesn't mean that one size, if say the one side is not decreasing, the other side can be decreasing. So still based on maximum dimension, you're not having a response, but in terms of volume, you are having a significant decrease.
Yeah.
So that's what we are looking at, and which we found that most of our patient had more than 50% reduction in volume, but the maximum dimension is like 20 to 30% reduction.
Right. Very good. And one thing that I've always thought about when SABRE has come more and more into favour for renal masses is that kidney cancer was traditionally thought to be radio resistant. So how have you overcome this challenge with the technologies that are available to you?
Yeah, so historically, like you said, like in 80s and 90s, even you would be surprised to say that we have adjuvant radiation trials as well, and which, as expected, never showed disease-free or any overall survival, but just toxicity. So historically, it was always considered renal cell carcinoma is radio resistant. And like for myself, I started my radiation training in 2007. And we were always taught, okay, radiation role is just palliation. That's it, nothing
It's
else.
mainly used in a palliative sort of setting to
Palliative,
control
yeah.
symptoms like bleeding. Yeah.
Yes, and so then the Sabre actually invent the Sabre and improved technology where we can deliver very high dose of radiation in a relatively small number of fractions, and we can spare the normal structures. So the high dose of radiation have a alternate mechanism of cell kill rather than typical radiation kill of DNA damage. They can have impact on the endothelial cells. They can have impact on the immune system. So that's how we are able to get rid of it. And another thing, the kidney saver is being used for last 20, 30 years for metastatic setting, like intracranial brain mets. It was being used for lung mets or other sites of mets from kidney. And the local control was always very high, more than 90%. And that's what we are seeing now. So like high dose per fraction, definitely we can overcome the radio-resistant of kidney cancer.
Yeah. Well, it's fantastic to have, this non-invasive way of treating renal masses in patients who otherwise wouldn't be eligible for an operation. So what is next? Surely some prospective trials, maybe think about moving SABRE into mainstream practice for people who would be fit for anything. Could it be given as an option for any small renal mass?
Yeah, I think at this time, definitely like in this paper, most of the patients are medically inoperable, older age cohorts. So surgery still remains the standard of care, particularly for T1 tumor. Partial nephrectomy is always the preferred option. So currently, anyone who is medically inoperable or not a candidate for partial nephrectomy for small masses, definitely SABRE is a good alternative. Going forward, definitely, I think we need to take it into phase 3 trials where we should compare with the other surgical modality like partial nephrectomy versus SABRE, or we should compare SABRE with thermal ablation, which is basically limited to 3 to 4 centimeter. So Shankar is already planning a fast track 3 where he is planning to look at like a multinational trial comparing partial nephrectomy and SABRE. So it's exciting time, but it can be always challenging. You know that like two cross modality comparison. And from the lung cancer, if we look at where they tried, multiple trial have failed, SABRE versus surgery. So it's challenging, but it is doable, and particularly involving people like Peter Mac, all the urologists are pro trial. So most of our
Pro trial, I like that. Yeah.
yeah. So we have a lot of like recruitment.
Yeah.
Like we don't have issues at all the like urologists at Peter Mac, and similarly finding good centers where academic oriented and they are keen to enroll patients on the trial, and then finding a way, because the patient once seen by the person who has seen the first and been portrayed as the treatment option of surgery, and then asking for a clinical trial. So most of the patients, they prefer to go the way the first consult was. So maybe looking at someone combined clinics, having radiation and surgeon together, and then getting the patient through, and then expecting that we can enroll. And because of the local failure rates are very low, there are chances that we can end up with having a quite a large trial. So it could be a quite tricky one, but I think that's where we should go forward.
Absolutely. And it will raise some questions about what it will be like to do salvage surgery after patients have been treated with SBRT. But I think future trials, looking at this in a prospective fashion, comparing to surgery, comparing to other non-invasive treatment or less invasive treatments, or even surveillance for small renal masses will be very useful and very informative in the future.
Yeah, definitely. I think it's exciting time, and for last 10 years, like SABR was just to prove itself like, okay, that is a good modality, non-invasive, minimal side effects. We can preserve renal function and good no impact, significant impact on quality of life.
Definitely.
So I think we have proved that in a relatively very older medical comorbids cohorts. So definitely it merits now comparison and going into a second step with
Exciting
phase 3 trials.
future indeed. Absolutely.
Yeah.
Mohammed, before I let you go, I know this great story about your name. Now, you in fact are named after the great boxer, Muhammad Ali.
Yeah.
It's your dad's a boxing fan, is that right?
Yeah, he was a very good boxing fan, and so he loved to watch his what you call his fights.
Yeah.
And then even in our culture, you must know that Muhammad is a very common name, another factor as well. So that was the reason that he named me Muhammad Ali. And
Very
I
nice.
get a lot from my patients,
Yeah.
and it's easy for them to remember.
To remember you, absolutely.
Yeah, that's really easy. And
well, Muhammad Ali, we're very happy to have you with us at Peter Mac, and thank you so much for joining me tonight on the EUO podcast. And congratulations to you and the rest of the team on this fantastic paper.
Thank you very much, Renu, for having me, and looking forward to be more on the Jiju podcast.
Very good. Okay, so I'm very excited about this episode's EUO Bio segment. A very good friend of mine, no stranger to GUcast, a great friend of the podcast and of European Urology. Welcome, Elena Castro, medical oncologist extraordinaire from Madrid.
Hi, hello.
This is odd seeing you on the big screen, Elena, because I'm more used to you sitting next to me. You were just recently in the podcast for our Prostate Cancer Olympics episode with Arun Asad. Do you remember that one?
Yeah, well, it was last year. It feels like it was yesterday. It was 12 months ago.
That's right. And I think I distinctly remember you saying doublet therapy for everyone. There's no role for chemotherapy, right? Something along those lines.
I don't think I said that. That sounds more like Declan.
Oh, that's right. Yes. So Elena, you're the supporting editor for the European Urology Oncology Journal. Tell us a little bit about yourself for the audience who don't know you as well as we do here. Tell us a little bit about your background and your research and academic interests.
Well, I'm a medical oncologist, and since I finished my training, I've been focused on prostate cancer and cancer genetics. And my research has been focused on the genetics of prostate cancer. I trained in Spain, then I did a fellowship in London at the Royal Marsden and the Institute of Cancer Research. And I did my postdoc with Professor Roslyn. We started working on the role of BRCA2 in prostate cancer. That was many, many years ago, and still working on that. And during my time at the Marsden, I met very good friends that now went back to their countries, and it's very nice to meet them from time to time in conferences. That is where we mostly meet nowadays.
That's right. And I think it was the ANZUP meeting that you were here for last year, was it?
That's correct.
That's right. Very good. Go on, sorry.
No, I was going to say that I even made friends that went back to all the way to Australia. So people everywhere. It's one of the very nice things of training in these excellent sites where people from all over the world gather, and then is where good science is being done. Now at Peter Mac, I think is one of these hubs in the world. Renu?
Well said, Elena. So let's talk about the journal for a minute. You're supporting editor. You're one of 3 medical oncologists on the editorial board. Now, this is mainly a urological journal, but it's an oncology journal as well. So it's a tough kind of criteria to meet. What's been your experience like working with a bunch of urologists? Must be frustrating for you.
Not at all. My experience is really good. I'm also involved in EAU, and I have to say that it's a very good experience. I'm getting to learn more about the urology community and what is of interest to you. And I have to say that we have so many points in common when it comes to uro-oncology, that I'm very pleased to be part of the editorial roster. I always feel like I'm part of the family, and I'm very, very happy to be there. But urology tumors require multidisciplinarity, and I think this is what we are trying to achieve in the journal.
Yeah. Absolutely. And so when you think about your vision for the journal going forward, what are your thoughts? What kind of papers would you like to see more of in the EUO journal? Where do we need to focus our attention?
I think what I would like to see more is original research. It doesn't need to be very big projects, but well-conducted studies. It can be phase 2 trials. It can be retrospective analysis. But it is important to receive original articles, and because there's a lot of research that is being done in different centers, different parts of the world. Sometimes we get studies that are very similar, and we have the opportunity to publish back to back, and it's nice to see how different people may come to the same or similar conclusions. But I think we are looking more for this kind of articles. Of course, if there is a good systematic review, it's something that, particularly if it's focused in something novel, the journal will also be interested in this kind of papers. But original research in different aspects of uro-oncology, I think is what we are more interested in.
Yeah, and I think also original research that comes from a really multidisciplinary team that crosses the disciplines of urology, medical oncology, radiation oncology, nuclear medicine. These are ideal things that we would like to see more of in the journal.
Yes, absolutely. And even if it's the name is uro-oncology, as you said, if there is a good staff coming from nuclear medicine or radiology or radiation oncology, we are always very open to also assess and publish those articles.
Fantastic. So we're halfway through the year, Elena, but there are some big meetings coming up. So I wanted to ask you, what are you looking forward to the rest of the year? What are the big meetings? Can you give us a sneak preview of what data you're looking forward to being released at some of these meetings? I'm sure there's ESMO, there's EMUC, there's ESMO Asia, lots of things to look forward to.
Absolutely. To be honest, I don't know what is going to be presented because I think we all have some studies in mind that may be released soon. But this is a bit of a lottery. You never know when the data will be ready to be presented at ESMO, or we will have to wait until ASCO GU. Because the good news is that there's now so many things going on in GU that in every meeting we have some novelty.
New. Yeah.
Yeah. So I don't know. So we have some studies of PARP inhibitors in metastatic hormone sensitive. We have some studies intensifying therapy in localized prostate cancer. We have so different things that should come out very soon, and I hope it's in 2025, but I don't know.
Yeah, we'll wait and see, but definitely an exciting end to the year, I'm sure. Now, Elena, EAU in Madrid was fantastic, but the only thing that I have to complain to you about is it was freezing cold. It was so cold in Madrid that whole time, and then as I was sitting on the flight ready to take off, the sun was shining in Madrid. What was up with that?
Yeah, I know. And the same happened with the last ESMO. So I'm starting to think that the organizers somehow managed to get bad weather. So everybody is inside the conference.
Inside the conference, yeah. Well, luckily I had your jacket to keep me warm. Thank you. Did I ever give it back?
Yeah, you did.
Very good. Well, Elena Castro, thank you so much for joining us on this episode of the EUO podcast. Elena Castro, everyone, medical oncologist from Spain. And that's all we have time for in this episode of the European Urology Oncology podcast. 2 fantastic papers and a big thank you to all the guests who joined me today. It is great to be able to disseminate their work among the wider GU oncology community. The links to both the papers will be provided in the show notes. Don't forget to subscribe to the European Urology podcast channel, where you can get regular access to the monthly EU Platinum Journal podcast hosted by Declan Murphy and Nikita Bart, as well as What's Your Focus by Christian Gratzky from EU Focus, and of course, regular EUO podcasts. We love getting audience feedback, so don't hesitate to get in touch with us. So goodbye from the GUcast studio, and we'll see you next time for the European Urology Oncology podcast.